In this video, we'll be showing the use of PFCL in the management of diabetic vitrectomy. In the first video, you can see there is a thick hyaloid face which is very firmly adherent to the underlying retina. Once the plane is created, PFCL is injected between the thick hyaloid face and the retina. The PFCL gradually separates the hyaloid from the underlying retina. It helps in membrane dissection. So PFCL not only supports the underlying retina, but it also pressure tamponades the bleeders. This is followed by further dissection with the help of a cutter only. Gentle dissection is being performed with the 25 gauge cutter only. As the posterior hyaloid face is separated from the retina, the PFCL further extends itself, seeps itself between the plane. Once all the traction has been relieved and the vitreous completely removed, pan-retinal photocoagulation is performed. Since no breaks were created, there is no need for silicone oil or gas tamponade. As we can see in the OCT pictures, the foveal contour has improved after 2 months and it has a near normal fovea. The vision also improved to 6/12 after 2 months. The second video is also a similar case in which there is presence of a thick hyaloid face which is firmly adherent to the underlying retina. There is presence of a subhyaloid bleed. So after creating an opening between the retina and the hyaloid face, PFCL was injected to further cause the separation of the hyaloid from the retina. So PFCL not only supports the underlying retina, it pressure tamponades the bleeders and it also prevents the formation of breaks. Further dissection is gently then carried out with the help of a cutter only. With the use of PFCL, the membrane dissection becomes much more easier, and PFCL also protects the retina from causing undue traction leading to breaks. Once the vitreous is completely removed, pan-retinal photocoagulation was done. This was followed by removal of the PFCL bubble. Remnant membranes and residual blood clots were removed. This was followed by air fluid exchange. Since there was no break, there is no need to inject silicone oil or intraocular gas in this case. In the third video, a tabletop traction retinal detachment can be seen. There was a very thick membrane which was firmly adherent to the underlying retina. Removal of this membrane could have created a break. So PFCL was injected and the membrane was gently removed under PFCL. This was followed by pan-retinal photocoagulation in the peripheral attached retina. It is very important to remove such membranes by gentle tangential traction to avoid the formation of any breaks. To conclude, PFCL are a very useful tool in managing difficult situations in diabetic vitrectomy. They can pressure tamponade uncontrolled bleeders. Firmly adherent membranes can be removed under PFCL. PFCL can help in membrane dissection and also en bloc removal of hyaloid face if injected in the proper plane.